So I'm Barbara from the French support group, and I have a question concerning the recent use of SGLT2 inhibitors, because we were talking about multidisciplinary approaches, and especially in AL amyloidosis, I saw it has also side effects such as hypotension. So is that not a problem in patients with AL amyloidosis?
Do you want to go first?
We can have two both sides of the questions. Yes, I think it's really an interesting medications that we can still use in amyloidosis. Of course, we have to titrate the diuretic doses beside, because it has an action of diuretics, and the blood pressure effects might be mitigated by the adaptations of the diuretic doses, the other ones. So we can skip, for instances, hydrochlorothiazides and replace by SGLT2 that have more specific cardio and renal protective effects. That's my point of view, but I let the cardiologist.
I completely agree. I use it. I use it because it improves symptoms and it improves prognosis. Still, what I already told, this is based on huge evidence in a regular heart failure population. There is some literature on ATTR patients. At least it doesn't show any harmful effects. Do you see many side effects? No. I mean, you get the usual things such as urinary tract infection. I don't see a lot of hypertension. What I do, most of the times, it's patients suffer from volume overload. So it's relatively easy to add that to the existing therapy, and I'm more happy to reduce the loop diuretics instead of the SGLT2 inhibitors. But that's my personal experience, or at least my personal practice.
Okay, thank you very much for this answer. I was just wondering when I saw this in the... Okay, and since I have the microphone, I wanted to add something. It's more a remark about the home care options. I think it's, of course, a great thing that patients have the choice for dialysis at home and so on. But just for all those home care options, don't forget the psychological burden for those patients, because, I mean, we saw it has lots of advantages, but just I know patients who tried that and who went back to hospital hemodialysis because it was just too heavy to carry, too much responsibility, and there were some incidents, so it's really a burden for the patients too. It's not only advantage.
Yeah, of course, it's not only advantages, and it has to be weights at the beginning of the decisions, but it has been shown that it's less intrusive than coming at the hospital twice a week, and it's really well tolerated because the patients don't need so much time to recover from dialysis sessions, which is quite longer in the hospital setting with the long journey. So what we do in our unit, we have a strong team that supports a lot of patients. We do remote monitoring, we do support with nursing at home. So it's, of course, you need the team that it's skilled enough to support your patients. And in fact, you really need to see what kind of patients might benefit from home-based treatment and what kind of patients. No one dialysis fits for all. That's just, I want to notice that. And especially for those with cardiac involvement, I had 2 patients. We really succeed in peritoneal dialysis, and I just would like that patients are aware that there are other options that can be smoother and less intrusive for them. But of course, we need to discuss that together. It's a shared decision-making process.
Yes, after the re-establishment of the, let's say, Kapalanda situation, that everything is in order, if you see that the NT-proBNP values are still deteriorating, what kind of drugs would you advise?
It's a question to me, I guess. It's difficult because please correct me. Of course, the BNP value is influenced by some hematological treatment, so you can't really use it anymore. Personally, I don't really use BNP as a guidance for therapy. There have been some studies that tried that, but they weren't really effective to show that, successful to show that. Of course, it is a suggestion that the heart still suffers, but there are many more aspects, such as physical examination, the echo, filling status on the echo, troponin, EKG, so it's a bunch of signs you get.
Okay, just to complete the information you provided this morning, it's already more than 5 years that my partner is suffering from amyloidosis, and we had quite a trip to go through, because we had to oppose the protocols delivered by the cardiologists, because they provided beta blockers for us, for my partner. So we had to go against their protocol, and this wasn't always that easy. It was rather hard to go against their protocol. It wasn't always accepted, but now as time has evolved, it's getting better now.
I mean, this is...
Start to accept the fact that beta blockers aren't really the best solution.
Yeah, that's true. I mean, what I try to show you, this is pretty new to a common cardiologist, right? And this is something we try to centralize in particular centers, which means that we don't see a huge amount of patients suffering from AL. It's more or less ATTR. And there are colleagues that haven't ever heard of a amyloidosis, right?
In fact, yeah, if I can just add something. Yeah. So we have a huge problem with the beta blocker treatment. Many years ago, it was contraindicated in heart failure, and we have very nice studies demonstrated the interest in heart failure patients to save their life. And now all the cardiologists are using beta blockers in heart failure patients. So if you have cardiac amyloidosis, you have heart failure. And that is why all the cardiologists that you will see, most of them would like to, would do everything to treat you with beta blockers. So you have to understand that it's very complex for us to change their opinion on that, because there is a lot of proof that it's working in heart failure patients. And of course, I'm convinced that it's not working in cardiac amyloidosis patients. I've seen my patients complaining when I was treating them 15 years ago with beta blockers. So the thing is that we need to do something together, because these cardiologists, and there is still different type of cardiologists, you have rhythmologists, heart failure specialists, etc., they don't believe in us. Us is the cardiologist specialized in amyloidosis. They don't believe in what we are saying. They don't believe in us, because they said, you have no proof. We have the proof, because there is so many papers. So we need to do something together, patients and cardiologists. So just a short sondage. How many of you have received a beta blocker treatment? How many of you? Okay. And so 10, okay. How many get worse on that treatment? Yeah. How many just stop the treatment? All of you. So still on beta blockers. So if you are good, it's good. Yeah. So the thing is that the things that you have to understand, if the disease is advanced, then you can get worse on beta blockers. And some patients will tolerate the beta blockers, will even improve on beta blockers. It's a very good treatment. But if you have an advanced disease or etc., you can really get worse. And even it can get really, really worse. So I don't know how we can do. Maybe we can do testimony, we can do something, a position paper or something like that. But we need to do something, because all over the world there is too many patients that are really getting these drugs and are getting worse. And from my point of view, some are going to die on this treatment. So.
And you're ready to fight with your cardiologist.
But it's a fight. I can tell you.
No, I mean, personally, I fight that it's not
Yeah, but you know, you are fighting, I'm fighting. You know, everybody thinks that we are mad when we are saying stop the beta blockers in AL patients, and even in some ATTR patients.
You are only a patient.
Yeah, but
He cannot say that to you.
oh yes, don't worry.
Probably it's about informing our colleagues and centralizing care. At least, I mean, I work in the Netherlands. I have a Dutch and a German background. The situation is completely different. In the Netherlands, you have 4 or 5 centers that look into amyloid disease. In Germany, it's just any cardiologist that want to treat the patient, and probably that's not the way to go. Yeah, I know that. So because they have the local cardiologist you go to, and there's sometimes referral to a like higher specialty hospital, but not always.
And if I may, of course I'm not a cardiologist, but one of the problems also is that even in the ISE, the Congress of the International Society of Amyloidosis, that are planning each 2 years, we are always presentation about these drugs, saying sometimes that, okay, you could use in some patient, it could help, but it's so small part of the patient, but it's I think it's also confusing for some people, because we are always seeing presentation about beta blockers in AL and transthyretin amyloidosis. So sometimes even for specialists and cardiologists that are following those congress, it could be also be confusing.
Really, what we can do is with the Alliance and all your association is to do something on internet and write something why beta blockers can harm patients, and then also so we can write something from doctors that patients can bring to them, and also add your testimony, you know, and saying how beta blockers, and I think if there is everything like that, so patient can be informed and they can inform their cardiologist and explaining why.
It's a difficult situation. The patient informing the doctor, that doesn't always work.
We always have to listen to the patient.
All the patients are experts.
Yes.
All the patients are experts, because it's impossible to know all the disease. So the patients are getting more informed than the doctors. That's what we are saying, and that's why we use our patients to teach their doctors. That's how we are dealing, and then they can recognize and diagnose more patients.
Just a naive question, a really naive question from a neurologist. There are no comparative study among the I suppose, like this.
So there is one Spanish study that has been shown at ISA meeting, and that has been shown in Madrid at the last patients congress, and I think it should be published soon, I think, but it was on ATTR patients. But I think when we are convinced that beta blocker is harming patients, and you can even kill them on beta blockers, it's very difficult for me to do a randomized study and treat the patients on beta blocker.
No, an randomized.
But that's what they want, in fact. But I have some ethical issue to do this study, because, you see what I mean? It's treating, 60 patients with amyloidosis in our center is what we do in 1 year. So we can randomize them and put them on beta blockers and seeing this patient getting worse.
No, just to take courts. I mean, you have that database, you have courts. I mean, I think it's difficult, but because otherwise nobody will do any choice based on beliefs, personal believing. So
using database, I don't want to take the microphone too much, but the UK, the NAC centers published a very nice study on ATTR, and it was a retrospective study.
Yes.
Okay, and they showed that finally the patients that were on beta blockers did better for ATTR than those that were not on beta blockers. But the things that the patients that were getting worse on beta blockers, the more advanced and the more severe, stopped the beta blockers. So they were in the group without beta blockers, but of course they were worse. And the conclusion that maybe we can use beta blockers. But if you are stopping the treatment in more than 25%.
There is still a question from
the
public.
So I have a question for Dr. Bisciglia.
Yeah.
So you shown us deposition in the stomach. And is the symptom pain, burning sensation in the stomach? And what are the treatment for that?
Gastrointestinal symptoms, it's a delayed gastric emptying and alternation of diarrhea and constipation. So fraction in meals, how to treat this? Conservative measures again, so fraction in meals and using some drugs that can help to the motility, gastric motility. So I mean, things that you will do even in another disease, so not specifically for AL amyloidosis.
Okay, thank you.
Thank you. Regarding to the other question just mentioned, how's the development on removing the already installed bad amyloidosis harm in, for instance, in the internals from the patients? Is there any medication already available for eliminating the already done damage inside?
On nerves.
On nerves, yes, but also on the autonomic system.
Autonomic system.
But yes, on both systems, in fact.
No, but it's the treatment of the disease, so it's the primary treatment of amyloidosis, because if you stabilize the serum protein chain, you may have a stabilization of autonomic neuropathy and peripheral neuropathy, but I think there is no other treatment. There is treating the disease, which is the basis, and we can only give symptomatic treatments because treat the disease, going to the origin of the problem is to the hematologist.
Yes, that's to stop the growth.
The production of, yes.
But to lower the existing damage, there's not really a solution.
No, because otherwise I will be unuseful, and we will be able to treat all the neuropathies of all etiologies. Unfortunately, we are not there.
I think he's talking about the studies on the new treatment.
It's on TTR, right? Yeah, because I mean, there's at least as far as I know, no additional treatment on AL, but there is upcoming treatment regarding ATTR. There was a publication half a year ago in a journal on a small, how do you call it? Now, it's a substance that induces the system, the body, the immunologic system to remove the proteins. And there will be a multi-center study it's already ongoing, and patients are already enrolled in that to show that this principle works.
Okay, that's good news, I think.
Yeah.
Hopeful. Yeah.
Definitely.
I've got a question for you, Michela. So the patient that have got a neurologic pain and are resistant to gabapentin and such treatment, what do you recommend after the next step? Because a lot of patients complain about this.
If we fail with gabapentin and if we fail with pregabalin, we can use duloxetine and we can use venlafaxine. And if we fail with this, also we will also do a try with amitriptyline or nortriptyline if there is not a big involvement of the autonomic system. And studies about using drugs in more drugs, for instance, a combination of gabapentin and duloxetine, the evidence is not it's not so clear. So monotherapy is a good choice.
If a patient is in remission, so they've had treatment and they're in remission for AL amyloidosis, does the advice on fluid restriction and salt restriction, does that still apply for the rest of their life, or is it only for the period of time that they're on treatment?
That's a difficult one. Personally, I never ever stop any heart failure medication in general. The question is, or the discussion is, what is remission? Is it removal of any signs in the blood? Or is it normalization of cardiac function and structure? I have rarely seen patients that showed no ventricular hypertrophy or ventricular thickening anymore, no abnormalities of any function whatsoever, which makes me think of at least continuation of some sort of treatment. We can still debate on the amount of diuretics, for instance.
Yeah.
And this is more tailored therapy according to symptoms and signs which I see.
Would that still be the case if the heaviest load was actually renal involvement as opposed to cardiac?
I think both are important, and the level of kidney and cardiac as well damage will in fact tailor the treatments of fluid restrictions along with diuretics and the new generation of diuretics such as glyphosate. But in fact it will depends on the reversibility of the organ involvements with hematologic remissions. You can have a good hematologic remission, you can achieve a good, but with a sustained level of kidney and cardiac damage, that doesn't afford for liberal diet or withdrawal of diuretics. So most of the times, what's regarding the kidney involvements, what we can hope for patients who have renal amyloidosis is to stop the process of future deposits, but most of the time the kidney functions doesn't recover or recover very slightly. But as I shown you on this guy, is achieve hematologic remissions, but because of diffuse deposit and scars, it keep on progressing to kidney failure. So that's we need to take into account that amyloidosis deposits are like glue and very difficult to remove. So that's the kidney or the heart damage are most of the time irreversibles, and so we have to maintain a kind of balance between heart and kidney impaired functions, and to hope that this level of impairment of organ involvement will not progressing with hematologic remissions. But I've never seen ever the complete renal recovery after seeing renal amyloidosis deposit, and I hope maybe it will change with the antifibrillin antibody if it's work in the kidney, because it's work well in the liver, but for the heart and the kidney is another things to remove deposits. So that's, there is a kind of part of irreversibility, but what we can do is to support and to avoid further deposition. So
I guess my fear was that if you started to consume more than 2 litres of fluid a day, are you increasing the likelihood of an acceleration of your CKD over the long term?
No, the problem is with CKD stage progressing is that the kidney is not able anymore to dilute the urine and to excrete free water. It has to be accompanied by solid so that you can have a kind of dilutions of your blood, which lead to hyponatremia, confusions, dizziness, so that the amount of fluid has to be linked to the capacity of the kidney to dilute the urine and to excrete free water. So I always say to my patients with mild kidney impairment, don't go above 1.5 liters.
Thank you very much.
Short comment? Yeah, short one. There has been a debate between nephrologists and cardiologists about the optimal dosage of diuretics. We see that we're on a common sense. What we think is that fluid accumulation, fluid overload of respectively higher venous pressure in the system is bad for the kidneys. So there is evidence that it's not a good thing to reduce the diuretics because of protecting the kidneys and accept a little more fluid in the body. That doesn't work. It gives harm. So please focus on fluid retention, get rid of it. Even though the kidney function deteriorates a little, still patients have a better prognosis in the long term. That's like that's more a philosophy we have in the recent years.
Completely agree. It's the volemia of the patients who care.
Okay, thanks a lot with this last very important information. I would to thank the three excellent orators and this very interesting session. And it's time for lunch. It's on this level. And no, it's not on this level. It's one level lower. Yes. Okay. Thanks to everybody.